Hello, this is Dr. Chris, and this is my electromechanical heart spiel. Very exciting day. Welcome to the beginning of cardiac. It's an exciting time. Cardiac's kind of the bread and butter of paramedics. I want to set the tone here kind of with the electromechanical piece. I think this is a good foundational chunk of knowledge for you to have. So, the first thing I'd like to do is talk about the mechanical action of the heart. And the heart, as you know, is a two-sided pump, double-sided pump. It's made up of atria on the top. So here and here, as you see my cursor, are the atria. And then the ventricles are on the bottom, number 3 and 4. And what happens is the atria are filled with blood. They both squeeze. The blood is squeezed down into the ventricles, and then the ventricles squeeze again. And in the case of the right side, the blood is pumped up into the pulmonary artery, so towards the lungs for oxygenated. So it's deoxygenated blood pumped to the lungs to get oxygen. And in this ventricle here, on the left side, blood is pumped into the aorta that is rich in oxygen to go out to the body. And really, that's a fairly simple concept. So double-sided pump, blood goes round and round. If you want to remember, there's also valves too. This helps me. If you remember TMPA, I say trademark in Pennsylvania, PA. That's goofy. I use goofy acronyms and things to help me remember. If it works for you, use it. If it doesn't, roll your eyes, walk away, make your own. But anyway, tricuspid, mitral, pulmonary, aortic. And know what? The pulmonary is on the right side, pumps blood into the pulmonary artery to go to the lungs. And the aortic, guess what? Pumps into the aorta. So that makes it nice to remember which side pumps to the lungs and which side pumps to the rest of the body. If that's that will be helpful to you to remember later. So that's the mechanical part of the heart. Then there's the electrical system. Electrical impulses generally start out in the SA node. At least they're supposed to start out there. That's the way we were designed. Our heart's designed to function. So it's the SA node. There's a factory preset on that, believe it or not. Yes, you come with a factory preset, and it's about 60 to 100 roughly. Of course, there's no specifics necessarily, but that is the general rate. And so that's what we call your inherent pacemaker rate of your sinoatrial node. So you need to know that the heart is capable of automaticity. That means that any cardiac muscle is capable of generating its own electrical signal. The only cells in the body that can do that. So what happens is a signal is produced in the sinoatrial node. It travels through many mechanisms down through the atria, and you can see here it travels even over into the other atria on the left side, and tells that atria to contract as well. So it travels there, goes down through the bundle of His, the AV node and the bundle of His, down through the Purkinje fibers, the bundle branches, the Purkinje fibers, into the rest of the heart. So what happens mechanically? Well, that happens. Well, in a healthy heart that's functioning as it should, the signal is produced right here in the sinoatrial node. And as it goes through the atria, it says, hey, atria, squeeze. And they do. Then the signal goes down through the AV node, hits the bundle of His, and the bundle of His puts the brakes on the signal a little bit to slow it down. And that's important because it slows it down enough for the atria to finish contracting before all the blood gets into the ventricles. If it didn't slow it down, the ventricles would start pumping blood out before even all the blood from the atria got squeezed into the ventricles, and that wouldn't be a good thing. So there's a delay, if you will, switch. I guess that's electrical work. And this is mechanical and electrical. It's plumbing and electricity. It really is. So the signal continues on down, past the delay, and then it disseminates through the ventricles and tells the ventricles, hey, now it's your turn. You pump. And then the blood gets dispersed up the pulmonary and up the aorta as appropriate. And that's how it works. Sometimes the sinoatrial isn't functioning right, or maybe not even at all. There's something called sick sinus syndrome that maybe you've heard of. And our body, or our heart, is set with a lot of redundancies. So if none of the atrial cells take over, then the AV node will take over, and its factory preset is 40 to 60. So you get a lower pulse rate, but it still generates a pulse, which is good. And if that fails, the ventricles, anywhere in the ventricles, can take over. And those inherent rates, factory presets, if you will, are 20 to 40. So that's not a pulse that's conducive to life if you're in it very long, but it can get you by for a while. So that's the electrical system. Other things that happen is sometimes there's random firing of other atria. The atria goes off, and then another one goes, hey, I want to go off too. And this one says, I want to go off. And then you get something that's called a premature atrial contraction. So in other words, it's a contraction of this atria before you expect it, and it registers on the EKG. But we'll talk about those a little more later. But that can result in a really fast heart rate if a bunch of atria are going off, and very ineffective pumping that needs to be fixed. So there's things we can do pre-hospital that you'll be learning about, but ultimately a lot of times what happens is either medication in the hospital, or they go in and do an ablation. So an ablation is like taking basically a hot wire, for lack of a better term, and cauterizing the errant cell. So this one's acting up here, now you won't anymore. So we kill that cell with some heat, and then it doesn't just randomly go off anymore. And you've got a ton of cells, so you can handle that. So that would be one of the things that could happen too. It can also happen down here in the junctional area, and then we could get something called the premature junctional contraction. And then of course the one you've probably heard of is the PVC, the premature ventricular contraction, and that's when a signal like randomly goes off in the ventricles. So the atria are doing their thing, but then you get this PVC mixed in there too, and it's pretty obvious on an EKG, and you will cover that later. So that's what's happening. So now I want to turn your attention to the right side and look at this EKG tracing. ECG, AKG, people use them interchangeably. I tend to say EKG myself, because C can be confused with E, which is an EEG, electroencephalogram. That's why a lot of people say EKG, but whatever works for you. Here's the isoelectric line. Think of this as sea level. So, this is the ocean. Anything above it is elevated terrain. Anything below it are like valleys and depressions. So we can have, especially when you talk about ST segment, you hear of ST elevation, ST depression. Well, that means it's either above or below the isoelectric line. That's what it means. So, and that ST segment part is what we look for in ST elevation myocardial infarctions, but that's a whole nother lesson. So the little boxes here measure time. Each little teeny square is 0.04 seconds. And a big box here, you can see the big box, that is 0.2 seconds. So we can measure how wide a complex is, and you can see here that that this complex is less than 0.12, et cetera, et cetera. That's what it should normally be, and this is the PR interval should be 0.12 seconds to 0.2. Otherwise, we could have other things like what we call a block, which you'll learn about later. So those intervals are important. I would recommend getting yourself a pair of calipers to measure these boxes here. You can, have to have them necessarily. You could use other things. I use paper in the ambulance. I just make a mark. Usually you don't see paramedics with calipers because they're pointing. We'd probably poke ourselves anyway, but we often get them in paramedic school, and then they gather dust in our drawer afterwards. But you probably get, if you have a colleague who's a paramedic, $10 says they got a pair sitting in their drawer with dust on them you could borrow for a while. If not, you can get them at a lot of medical supply stores, online. I'm not sure if the bookstore has them. They might be worth a call over there to see. Even a drafter's pencil will probably work, because that's the concept, is you put one point here and then measure how far it is to the next one. That's all, and then you march it out. So even a cheap drafter's pencil would probably do just as good in my mind. But if you want the fancy stuff that you got to pay more for because it's medical, then you can get yourself a pair of EKG calipers and have those in your pocket. Very exciting. So now that I've talked about the overall EKG boxes, etc., I want to talk more about the waves and what's going on mechanically. So here's the isoelectric line, the pause, and then there's a P wave. And as that P wave happens, that means the atria, those top two chambers, are squeezing or contracting, because muscle movement makes electrical energy, and that translates into this tracing. Then we have what's called the QRS. Here it's called the interval. You'll hear it called the QRS complex quite a bit. We can use them interchangeably and somewhat regional. I tend to hear QRS complex a lot more, at least in my circles. But either's fine. Everybody will understand what you're talking about. So the QRS is actually where the ventricles squeeze. So they squeeze much harder. They're stronger. Release more energy. So you got that QRS, which is all the ventricles squeezing. And then a little bit of time, and then the ventricles relax, because relaxing muscle also generates a signal. And you're thinking to yourself, hey, you missed something. Where are the atria relaxing? What the heck? That is a good question. You are right. That is missing, and it is still happening. Problem is, the atria relaxing happens on such a small scale compared to the ventricles, and at the same time, so they don't generate as much electrical energy, and they relax as the ventricles are squeezing. So the ventricle signal just overshadows the atria relaxing, and you can't see it, but it's there underneath. So that's what's going on. So when you start looking at your EKGs now, I'd like you to start thinking of atria contracting, ventricles squeezing, at the same time the atria relaxing, and then ventricles relaxing, and then repeat. It's all that's going on in your rhythm for a normal sinus rhythm. That's what's happening. We don't have any, we'll talk about it later, ST elevation. There's no undue spaces between the P's. The QRS is not unduly wide. All those things appear normal. You can also determine heart rate by counting these boxes, and I know there's references to that in your book. It's like a 300, 150 going across the boxes, and then you can count across and determine what your heart rate is. And yes, your monitors will show you too, but are they always accurate? And does electrical always equal what the mechanical is? Not always. Sometimes the electrical and the mechanical are a little mismatched. Think of it like your engine clicking, but your motor's not turning over. So make sure your pulses match the monitor, would be my word of caution. So that's my electromechanical heart spiel in a nutshell. My objective was to kind of pull this together for you and give you a foundation. I hope I did that for you. And I leave this with you, and we'll talk to you again soon. As always, contact me with any questions, and have a good day.